Thank you for the introduction, and thanks to the organizers for the opportunity to share our data. I'll be presenting this on behalf of my collaborators and colleagues from the Center of Public Health and Human Rights at Johns Hopkins, as well as collaborators from TB-HIV Care Association in South Africa and the Human Sciences Research Council in South Africa. You've already seen this slide essentially from a co-presenter, so I won't spend a lot of time on it, other than to just say we know that female sex workers globally are disproportionately affected by HIV, and this is also true in Southern Africa, where this study takes place, South Africa specifically. Less is known about engagement in the HIV care continuum amongst female sex workers. Data has been recently emerging, though, in this area. A systematic review and meta-analysis published last year by Mountain and colleagues found that around 39% of female sex workers living with HIV are engaged in care. Similarly, data from 3 different study sites in Zimbabwe from Francis Cohen suggests very similar findings that the majority of women living with HIV are not on treatment. The objective of this analysis was to assess engagement in the HIV care continuum, or Cascade, amongst female sex workers in South Africa. Specifically, we're looking in Port Elizabeth, South Africa, and we'll be identifying predictors of ART uptake. So prior to study launch, we did extensive community engagement led by our partners with the community advisory groups. This study actually was a study designed to assess PMTCT-related risks amongst female sex workers, and there is a poster in the late breaker session presenting some of those findings. The study was done in Port Elizabeth. As I've been saying, it's a coastal town roughly halfway between Durban and Cape Town in South Africa. It was conducted from October 2014 to April of this year. It's a cross-sectional study, also using respondent-driven sampling, similar to the methods that Dr. Lane presented earlier. The eligibility criteria for our study was 18 years of age or older, currently living in PE, assigned female sex at birth. Sex work had to be the principal source of income in the past 12 months for these women, and they had to present with a valid RDS coupon. All participants completed a questionnaire covering demographics, reproductive health history, behavioral questions, human rights related questions, as well as engagement in healthcare. We did HIV counseling and testing as part of the study for those who tested positive, point of care CD4 testing. RPRs were done to test for syphilis. We also did urine-based pregnancy testing, and we were not able to do viral loads on all women, but we did viral loads for women living with HIV who were pregnant. So here I'll describe the engagement of participants in the HIV care cascade and look at associations with ART uptake using robust Poisson regression. In terms of who the population was that we recruited, we recruited 410 sex workers in PE. The majority of them were relatively young, under 35. The majority had some education, but primarily just some secondary education. 83% were Black African, and nearly all of the participants were actually South African. About half were in a relationship with a boyfriend, partner, or husband, and about 3/4 had children. In terms of the HIV prevalence that we saw, I think these numbers reflect what was presented earlier from other different sites in South Africa, both in the crude and RDS adjusted weighted analyses. We see a 63% prevalence amongst these women. We also saw a very high prevalence of syphilis in this population, which is of course a concern. And again, these are compared to a national prevalence in the adult population of about 18% and about 30% amongst pregnant women. If we look at the engagement of sex workers in the HIV care cascade, what we see that's really encouraging here is that largely women are getting tested, and I think this also reflects results that were shown earlier. And in the study, we saw that the majority of women living with HIV actually were previously diagnosed. We didn't see huge drops in the cascade that were due to our eligibility. Again, We were doing point-of-care CD4 testing, so we did have that data. But where we see the biggest drop in the cascade is amongst those who have initiated ART. Some drops in terms of women who were initiated and are no longer using, but really large drops at the point of initiation. And so if we just sort of looking at the same slide, but thinking about it in terms of the 90-90-90 targets, you know, again, we're doing a good job, a relatively good job. Of course, we could do better at getting women diagnosed, but not doing a good enough job at getting women onto treatment. And unfortunately, the viral suppression component of this cascade we don't really have answers to, but obviously we're probably going to see a big drop-off there as well. What I can tell you is that amongst the pregnant women that we had viral loads for, 0 out of 10 of them were virally suppressed. And this is a population that you would think actually would be more likely to be virally suppressed, particularly because South Africa has the Option B Plus program. Even before that, they had Option B, so women who were pregnant really should be engaged in antenatal care and on treatment. This is just showing some of our findings by age. What I really wanted to stress here is that just like we see all over the world, there's an increase in prevalence with age, but here we really are seeing a high burden of HIV amongst young sex workers as well. By 18-19, over about 25% are living with HIV, going up to over 40% by 20 to 24. And we're also seeing that really engagement in ART care isn't really picking up until their 30s. So these are really young women who are both at high risk for HIV infection and also who services in terms of treatment isn't quite reaching. Looking at predictors of ART coverage, we assessed many things in univariate analysis, and I'm just presenting here the adjusted prevalence ratios, and I'll just highlight a couple things that I think were really particularly interesting that we saw. One was that being a mother, mothers were actually less likely to be on ART than non-mothers. Again, this is a finding that coming from an interest of prevention of mother-to-child transmission is definitely a concern. And also, we saw that women who had not disclosed to their non-paying partners were much less likely to be on ART than women who didn't have non-paying partners. So I don't think it's much of a surprise, but I think it's worth emphasizing that disclosure plays a huge role in ART uptake in this population as well. And this analysis was limited to women who had been previously diagnosed and were ART eligible, because obviously those would be big barriers as well to ART initiation. So there's several limitations to this study. Of course, it's cross-sectional data, and we unfortunately did not have viral load data available for everyone. HIV diagnosis and ART use were self-reported. However, given that the majority of women living with HIV reported prior to the HIV test on site that they had been diagnosed, it seems like those underreporting of awareness of status was probably relatively low in this study. One may also wonder, though, given the high level of prior diagnosis, are we oversampling those who are most likely to be engaged in services, and are we missing a population that services are not reaching, and in fact maybe overestimating engagement in care? So in conclusion, we found a high awareness of HIV status, and this likely reflects impact of taking testing to the community. We work closely with TB HIV Care Association. They are partners in this study, and they're offering mobile testing and point-of-care CD4 counts in Port Elizabeth, and so it would seem that this has been effective in terms of helping women to become aware of their status. Unfortunately, we're not seeing quite the same gains in terms of linking those women from testing to ART care. Our findings are very comparable to those in other studies, both the systematic review and also Dr. Lane's. And I think it's really important to emphasize that we're really not doing enough to reach young women, both with prevention and treatment. This point was also made earlier by others, but given that we're seeing the biggest drop in the cascade in terms of treatment initiation, we need to think creatively about how to get those services to the community, to women, and decentralized ART provision, community-based ART provision may be important solutions to help close that gap. We do know, however, that disclosure of HIV status is a barrier to ART. We saw that in our study, and so making sure that if we're going to be doing community-based services, that we can make sure that we're protecting confidentiality and women feel safe to engage in those services. We did see that mothers were less likely to be on ART, and we again saw that none of our women who were pregnant and living with HIV were virally suppressed, so there really are continued ongoing risks from mother-to-child transmission, and programs need to be put in place to help address that. Finally, universal coverage of ART and PrEP are essential to improve health outcomes and minimize onward transmission, and hopefully we'll be able to get those to this population better in the near future. I'll just acknowledge my co-investigators and all of our partners, and also our funders, MacAIDS Foundation. Thank you.
Thanks very much, Cherie. I think we have time for a couple of questions before the end of the session. I had one quick question. It was great to see Port Elizabeth represented. We don't see a lot of data on sex workers coming out of Port Elizabeth. I wondered how generalizable you think that these data are, both in terms of the services that are provided, and I mean, clearly the HIV prevalence seemed to be similar to that presented in the metropolitan area, but in other parts of South Africa.
Yeah, well, Port Elizabeth is different from some other larger cities. I find it, I guess, encouraging in terms of the generalizability that they were so similar to what was presented by Dr. Lane, although discouraging that the prevalence is so high. Clearly there's a lot of work to be done. I think a lot of people might have expected that prevalence in Port Elizabeth would have been lower, and unfortunately that's not what we're seeing. I think that we're seeing a pretty consistent message throughout the country that there's a huge need to get services to this population.
We have one question at mic 3.
I'm not sure if I missed it, but I wanted to ask, was there any data collected on the women being aware of the benefits of being on ART, so being on treatment and the protection towards their children, etc. So was there any data collected around that in order to understand the community awareness and the personalized incentive to actually be on treatment?
Yeah. We didn't ask specifically that, but we do know from conversations with the women and other qualitative work that we did that the women were relatively well educated about HIV and about the benefits of treatment. In the qualitative work, they really talked about, barriers in terms of time to get to the, time spent at the clinics, and also the way that they're treated at the clinics. And I think that's not just an issue faced by sex workers. I think the issue of waiting in long queues and feeling like the quality of care isn't great is something that the whole country is facing. But obviously, when you're coming from a stigmatized population, you may feel some of that, judgment and other challenges within the health sector even more.
Thank you.
If I may ask a question, given how important disclosure was, did you have any chance to look at whether there is any relationship between disclosure and self-identification as a sex worker?
We haven't looked at that yet. This is relatively new data, but I think it's a good question and something to potentially consider. We haven't really delved a lot into the data in terms of how women identify. We've been more focusing about how women identify as mothers rather than as sex workers in the data, but it's a good question, a point well taken.
Thanks very much, Cherie. I think with